So there are several proposed additional thrombolytic therapies which you can use. I don't want to use the term rescue, but you can use adjunctive maneuvers. And those include, for example, you can, when you observe on the final angiography imaging that the patient has incomplete reperfusion, you can, for example, go in with a catheter, microcatheter, and give intra-arterial thrombolytics. You can give additional antithrombotics. You can do secondary distal mechanical thrombectomy. So there are few options, few of these additional reperfusion efforts, but presently, as the things are rolling right now, none of them are confirmed to be 100% safe, or there isn't really a standardized guideline either when we're talking about the European, American, international, it doesn't really matter. There isn't a standardized pathway, a standardized guideline, which can actually tell us, oh, this is the best option and this is the best way to go. So in this, it would be really unethical and unfair to expose patients to have unneeded or unnecessary risk, because all of these additional reperfusion efforts, they can, of course, help with reperfusion, but they can also do harm. When we get into arterial thrombolytics, we can involve hemorrhage. When you go with a secondary distal mechanical thrombectomy, you can rupture a blood vessel, and that patient will not have a good outcome. So we tried to see how it would be best to, let's say, select patients who would be most likely to benefit from these additional reperfusion efforts. And apropos that, we developed a clinical prediction model, which can be used to advise the interventionalist or advise the treating physician on whatever that patient will be more likely to benefit from additional reperfusion efforts or not. So in this sense, when we're talking about delayed reperfusion, those patients who would develop delayed reperfusion, these would most likely not benefit from additional reperfusion efforts because that would be unnecessary risk. So in those patients, when we have incomplete reperfusion, and then we can estimate with high probability that that particular patient will develop delayed reperfusion, then we can stop the treatment at that point. But conversely to that, those patients who would be more likely to develop persistent perfusion deficit, then those who would more likely benefit from additional reperfusion efforts, such as secondary mechanical thrombectomy, intra-arterial lytics, etc.